Next, I would like to introduce our Gail G. Arnold Lecturer, sponsored by the Children's Hospital Foundation in Richmond, Virginia. It's Dr. Andrew Gordon. Please come up to the podium. So Andrew is a professor in movement science at the Teachers College, Columbia University. He received his master's from Pennsylvania State University and PhD in neurophysiology and pediatrics from the Karolinska Institute in Stockholm, before completing a postdoc at the University of Minnesota Medical School. In 2001, he published a landmark study evaluating constraint in children with hemiplegia, and then he's also been instrumental in developing a treatment called HABIT, hand-arm bimanual intensive training. His current work focuses on applying research-based knowledge towards developing evidence-based therapeutic interventions. Andrew, the podium is yours.
Okay. Thank you, Darcy, and the Scientific Program Committee for inviting me. It's a truly honor to speak to the Academy. So before I start, I just want to acknowledge that I've had financial funding from a variety of grant sources listed here, and I will not be discussing off-label use. I also, before I start, want to acknowledge, like Peter, I've been very fortunate to work with a group of talented students, postdocs, and collaborators, both here in the US and internationally, and I too learned from them, and they are integral in the work that I'm going to present today. And I'll try to point out some of the individuals as we go through, but just in case I forget some of them, they're listed here. Okay. So I'm coming to you from New York City, and when you think of New York, you don't normally think of humpback whales, but this was a photo that was presented in the New York Times, or showed in the New York Times about a month ago, and as an avid swimmer, it certainly caught my attention. I'm coming also from Columbia University, and more specifically from Teachers College, which is the graduate school of health, psychology, and education at Columbia. On previous occasions where I've presented at various courses and verbal presentations here, I've been told that, well, okay, my work is great. It works in this sort of ivory tower in a lab, but what about in the trenches, in the real world, where you don't necessarily have the luxury of the space and the time and the staffing and so forth to be able to either address these questions or apply it to therapeutic interventions in the real world? And well, first I want to acknowledge that indeed I do work in a tower. In fact, it's the ugliest tower at Columbia University. It's named after the eminent psychologist Edward Thorndike. But in this tower, my philosophy has been that first we need to find in very carefully controlled environments potential treatments that work. And then we can figure out how to translate this to practice, and I'm going to need your help to continue to try to do this. What keeps me awake at night is the idea that my friend and colleague Karen Adolph at NYU has been saying for years, and more recently quantified in a paper, but basically she has documented that it takes 1 million steps for an emerging infant walker to gain proficiency in walking, in locomotion. So if it takes that many steps, that much practice, that many falls, how is it possible that we think we can provide effective treatment 30 minutes a day, 3 times a week? That really is an important concept in terms of trying to think about, and this isn't typically developing children, but how do we think about providing intensive practice opportunities in individuals with developmental disabilities? So in this very talk last year, Iona Novak presented her evidence bubble, basically showing the red, yellow, and green light approaches or levels of evidence for a variety of treatments, and in this case focusing on improved motor activities. And what you'll see is in the green bubbles, which represent good levels of evidence, there's a common theme here. First of all, they're all intensive. They all involve intensive motor practice of activities. And second, for the most part, they involve motor learning theories of rehabilitation. So when I say that, this has really started from the work of my former retired colleague, Anne Gentile. And she said more than 40 years ago, and it was more initially in her application to physical education and sport, but eventually she and her students developed this for rehabilitation and neurological rehabilitation. But don't mislead the learner by telling them a movement form that you think will work. It's basically the learner that has to discover the form. You need to establish the goal, set up the regulatory stimulus, conditions, the environment, and then basically adopt that environment to elicit the behaviors that you want to achieve. And of course, she, like many of you, were focused on the idea that it's function or accomplishment of goals. It's very much part of our daily lives, and that's what we're trying to achieve. And all of this involves problem solving. So these approaches basically all have in common that you're trying to get the learner to figure out their own solution to the constraints that they're working with. Iona last month published a sort of modification of this theme. So in addition to what I just described, which and she basically pointed out that these are largely in unilateral CP focusing on the whole person and the upper extremity. What's conspicuously absent from this is good levels of evidence of approaches that are focusing on the lower extremity at this point. And that's something I would like to come back to later in the talk. More importantly, when you get to bilateral CP, you can see that at this point there are no good levels of evidence for approaches focusing on either the upper or lower extremity. And that's also something, when we think about to boldly go, this is an area that I think that we absolutely, as a community, need to boldly go. Okay. So it was more than 15 years ago that I started coming to the Academy, and I remember my first presentation in San Antonio very well. It was on a study of prehensile forces during grasping in children with cerebral palsy. It was a follow-up of the dissertation work I did with Hans Forsberg in Stockholm, before that. And I remember two things particularly well about this particular conference. One is that at that point, there were very, very few people doing work focused on the upper extremity. Largely, the work was really on gait. The second thing that I remember is Rich Stevenson was the chair of my session, and unlike my picture there, you can see that he looks very much the same as he did more than 15 years ago. Okay. So, as a consequence of presenting this, the series of grip studies over a couple of years, I became known as the grip guy. Okay, the guy focused on the hand. Okay. So, using this simple paradigm, we did a lot of studies focusing on basic motor control and basic motor learning and development. We basically looked at mechanisms of sensory integration to adjust grip forces to object properties. We looked at movement execution issues and motor planning. And one of the things that we described to our surprise, we found that motor behavior changed over development. Basically, there was an improvement in hand function over the course of development, and that wasn't really something that I had really thought of at that point. The other serendipitous finding that we had is that we found that the behaviors improved over the 1-hour testing sessions that we had kids participate, and that cued us into the idea that intensive practice is an important component. So, along with Susan Duff at the time, we presented a series of studies basically showing that the simple act of grasping an object between the fingertips, for a typically developing child or adult, it's a one-trial learning paradigm. Basically, you lift an object, you get a sense of its texture, its weight. The next trial, you adopt the forces instantly. And some of our earlier studies had shown that kids with CP don't do that. But what we found to our surprise is that over repeated exposure to the same objects, in this case 20 or 25 trials, they began to adopt their motor behavior. So they learned. It was a delayed learning, but with intensive practice, they got better. And we wrote, in the conclusion of our paper, basically, first of all, that impaired hand function is not static, and that went against everything that at least I thought about CP at that time point. But we also kind of wrote blah, 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 which may have direct implications for therapeutic intervention. Now, you see this phrase in many, many papers. And I can tell you that in 1999, when we did this study and we wrote that, I didn't mean it, okay? I had no idea. It's like, yeah, okay, therapeutic implications, okay. Please don't retract that paper, but Peter. Okay, so I remember describing these findings to my colleague at the time, Anne Gentile, again, the sort of grandmother of motor learning, and she kind of smiled and said, oh, that's great, and she put her hand on my shoulder and said, so are you going to study this the rest of your career? It was kind of a, cutting, direct comment that, really kind of caught me off guard, and I, started to think about it. It's like, maybe I could add a finger and do 3-fingered tripod grasping, okay? Or wait, whole hand grasping, okay? So you laugh, but actually that's in fact what we did. I was pre-tenured, basically needed, to have, safe, doable studies. I had no idea how complex adding digits to, understanding the motor control of that, given the increased degrees of freedom. But these are things that we actually still do to this day. But perhaps, the bigger picture that I eventually got to after losing lots of sleep is the question of, how do we provide opportunities for intensive practice and basically the clinical settings? So I went to the literature, the basic neuroscience literature, going back more than 100 years to the work of the grandfather of neurophysiology, Sherrington and Monk, and basically, already where they were looking at the effects of restraining the limb of an animal, and this was followed up, of course, with Ogden, adding shaping the environment to elicit motor behaviors, and then, of course, Taub's animal deafferentation work, and a number of others looking at pyramidal lesions. And then finally, the neuroscience, the neuroplasticity work that's been coming out over the last 15 or 20 years that really has shown that plasticity is driven by repetition, increasing complexity, motivation, and reward. And this got us thinking about, well, how do we go about doing that? And then as I think one of the parents pointed out, that we need to be looking at what's going on in the adult stroke world as well. And they have been considerably ahead in certain regards of clinical rehabilitation, largely, unfortunately, because of the amount of funding that's devoted in that direction. But what, of course, we found is that more than 30 years ago, Steve Wolf and colleagues, had already done some case studies, and then eventually, a larger randomized trial of forced use where they restrain the less affected upper extremity of an adult hemiplegic stroke patient, and basically passively, allow practice to incur. And then Ed Taub, of course, back more than 20 years ago, added the shaping and, formalized the procedure in terms of active training and termed this constraint-induced movement therapy. And there's, lots and lots of reviews and a multi-site trial on this in adults. Okay, so already in the late 90s, we decided to pilot this in a case study series with Jean Charles, my doctoral student at the time. And we started in the home environment, and we tried to modify this approach to be child-friendly. We used a cotton sling for restraint, and tried to use the child's home environment and interests to really elicit, age-appropriate motor behaviors to elicit practice. And we basically published the first constraint therapy or constraint-induced therapy paper in 2001. And there had been, of course, some forced use and splinting and other types of studies previous to that, but this was the first, kind of adding the formalized ingredients of constraint therapy. And I became known as the constraint guy at that time. So since that time, and this plot was modified from a histogram that Jill Heathcock had provided to me, done by our students. And you can see that from our 2001 paper, there's been an escalation in interest in terms of studies and reviews and basically commentaries and so forth about constraint-induced movement therapy in the pediatric literature. And there's more than 80 studies that have been done and more than 30 randomized control trials. And all in all, they've been very, very positive. Basically, it works in most cases. And these are nicely reviewed in a number of recent reviews that you can see here. Okay. So just to summarize, I'll sort of take you on a sort of a personal journey of what we've found. And these certainly were not found in isolation. I apologize if it comes across that, well, we were the only people doing this. I think at this point, a lot of people have contributed to our knowledge along the way as well and done parallel and similar work. But since that point, we had modified our approach to be done in a day camp setting. And in 2002, we started our first day camp, and we've done 27 day camps of constraint therapy, and as I'll talk about in a minute, bimanual training, basically with more than 200 kids across a variety of ages having participated. We know that it works one-on-one in the home environment. We know that in a camp environment, it works for most children, basically, and it's intensive practice that's really associated with the constraint therapy that is driving the motor improvements. Across the children that we initially looked at age effects, we see very similar outcomes. So in terms of plasticity, at least starting at this point, you don't seem to be, they're not held back by age. And I should say that older kids typically work harder for their gains. And of course, a number of people, Sharon Ramey and Ann-Christine Eliasson, have kind of taken this into younger populations, and of course, the individuals are taking it into older populations as well. We also found that a repeated dose of constraint therapy, the effects effectively were additive. And I want to show you that. So this was a group of kids that we first gave constraint therapy. And this is the Jebsen-Taylor test of hand function. It's a timed battery of a manual dexterity test, so the faster the time to complete this battery, the better. And you can see that after the first dose of constraint therapy, 60 hours given over a 2-week period, there's a reasonable improvement in their manual dexterity. We brought them back 1 year later, and on average, they retained the gains that they had in manual dexterity. And we gave them a second bout of constraint therapy. And you can see continued improvement. So one is, this is really, really illustrating the point that intensity matters. But the intensity doesn't have to be given all at once. And maybe we need to be thinking about constraint therapy as one of many approaches that can be provided to give intensity over the long course of developmental rehabilitation that you're going to need to do. And when people profess that, well, there's only one way to do it, otherwise you're losing opportunities, well, there isn't a lot of evidence that any method is any better than any other method. And this basically a breakfast session on Saturday that's going to focus on that issue. But more importantly, the way that I've come to think about it is, why would you trade off anything that is less child-friendly for the potential small amount of additional gain when this is something that you can do, again, as seen needed? So you want to basically keep the focus on children, as, again, some of the parents had pointed out. And as I said, there's a breakfast session on Saturday morning that's going to kind of give some summary of what's known about constraint therapy and some of the key questions that remain, basically. And I was lucky to participate in and publish a paper describing this with some international colleagues, mainly from Europe and Australia, basically, and this will be presented later. Okay. So around 2003, 2004, a lot of people started doing constraint therapy. A lot of clinicians were adopting this, and I became a little bit disenchanted when I started hearing about people casting kids and sending them home without changing the environment and training the parents, and really thinking that it was the restraint rather than the practice. And this kind of, in a way, forced us into thinking about the idea of bimanual training and thinking about, well, why might this be an alternative to constraint therapy? So some of the rationales that, that came to our mind were that, first of all, as you all know, even in unilateral cerebral palsy, both hands are affected to some extent. In fact, the coordination of the two hands is often impaired. And we know that many bimanual movements are never practiced. They have a great, less affected hand that they compensate very, very well with. There's always a potential for the restraint being invasive. It doesn't have to be the case, but if you cast a kid and send them home, there are potential side effects of that, and we don't really know enough about that. We also know in animal models of CP, which I'll talk about in a little bit, in the developing kitten, if you restrict movement of one of the forelimbs, you'll permanently disrupt the development of cortical spinal connections, the connections from the brain to the spinal cord, and impair movement. So that to me suggests that you have to have some caution about long-term restriction in developing infants. Unlike the unilateral impairments, bimanual coordination problems may underline some of the function, as many of the clinicians in this audience are very well aware of. We found that when we asked parents about the functional and play goals that they have, and for the children as well, more than 85% of them were bimanual in nature. And then during bimanual movement, some of our basic studies with the grip paradigm that I showed you earlier have shown that the less affected hand can effectively serve as a template in terms of informing object properties and maybe even the motor commands that are needed to drive the use of the more affected hand. And therefore, we came to the conclusion that the goal should be to increase the functional independence of improving the use of both hands in cooperation. And constraint therapy, as promising as it has been and as good evidence as we have for it, without a transfer package to bimanual function, it doesn't actually target that. And we can talk more about kind of the combination of the two later. As a consequence of publishing this, I became known as the bimanual guy, and for some reason, the anti-constraint guy, which isn't true. We basically took a tool that is used in physical and occupational therapy, bimanual training, and we formalized it. We made it very structured, very much like constraint therapy, with very specific rules for how to adapt the environment and when to change the constraints to elicit more skilled practice, and basically provided it at the same intensity as constraint therapy. And we term this, as Darcy said, hand-arm bimanual intensive therapy, or HABIT. And the idea basically is also to elicit practice, but doing so by modifying the environment and providing opportunities to engage in motor behaviors that require the use of both hands. So there's no restraint in bimanual training, obviously. It's the same duration, 60 to 90 hours, typically in our case in day camp settings, over a 2 to 3 week period. And again, the activities are driving the use of the affected hand. And we generally try to conceptualize, very much like the assisting hand assessment, kind of a gradient of behaviors, with the most simplistic being just using the affected hand as a stabilizer, a passive paperweight in some cases, and then gradually as motor skill increases in each task, try to elicit use as a passive or active assist, with the ultimate goal of trying to elicit manipulation capabilities in the affected hand. And we published a number of small randomized trials basically showing the promise of this treatment approach. So 3 years ago, we published a larger randomized trial of 42 children comparing constraint therapy and bimanual training in a day camp setting. And basically, it was 90 hours of training, and basically, we followed the kids over a 6-month period looking at hand function. So again, this is the Jepson-Taylor test of hand function. You can see from the pre-test to the post-test, there's a large improvement in both groups, red being the habit group and blue being the constraint therapy group, and that this was maintained over the 6 months that we studied this. Okay, so dexterity improves, in this case, about 30%. So to put that in perspective, in this 3-week period, that improvement is more than double the change that we documented in a 13-year developmental study of hand function. So this intensive practice has the capability of really kind of very quickly driving improvements or changes. Not curing the hand, it's not a miracle, but very quickly you can enhance dexterity. This is the assisting hand assessment developed by Lina Kronlinda Sundholm in Stockholm. It's basically a videotaped analysis of the quality by which the child chooses to use the affected hand as an assist during bimanual activities. And higher the score, the better. And again, you can see that from pre to post testing, both groups show improvements in how they choose to use their hand as a bimanual assist. So from this, we conclude that effectively both work. I remember one of my postdocs presented, I think, this particular study, and I think it was in a session where Roz Boyd also did some parallel work. And this, basically, there's a number of other individuals who have shown the same thing at that time and since. And I remember one of the clinicians, I think it was an MD from Virginia, stood up, and he was a little bit annoyed about, kind of the findings about bimanual training, and he kind of said something to the effect of, well, 20 years ago, you said we should be focusing on bimanual training, and then suddenly everybody started saying you should be doing constraint therapy, and now you're saying back to bimanual training. And I totally understand the confusion. And for my adding to that confusion, or to, kind of this small issue of, well, which one is better, I apologize to this academy, because the issue isn't which one is better. The issue is that these are two separate approaches that can be used, or you can choose to use these as you see fit, basically to elicit practice with the affected motor, the affected upper extremity. So, and I'm not saying that they're the same. They are different. On average, the improvements are the same. There are certainly individual differences among kids, and that's something that maybe we do need to figure out. We also need to figure out a little bit more about the kind of the neuroscience, which lesions are going to predict improvements, and which approach is better depending upon the particular neurological compensations that you have. But basically, they both work, and they can be used interchangeably, they can be used additively, and since you have a long period of development, you can try them, sequentially or together or whatever you want. Okay. So my colleague Kathleen Friel, she's at Burke Cornell Rehabilitation Institute in White Plains. She, along with Jack Martin, my former colleague at Columbia, had developed a Feline, a cat model of constraint-induced movement therapy. So basically, the idea is that you take a cat and you inject mucimol into the motor cortex and basically create animal model of hemiplegia. And you take the less affected upper extremity, or unaffected in this case, and you tether it into a jacket. And you do that 23 hours a day. And then for one group, that's all you do. And the other group, basically you add 1 hour of active training. And this can be done, basically, she did this in new kittens, or really young kittens, basically, and then after 8 to 13 weeks of age, which is considered the critical point for which the cortical spinal tract has been developing. So the work can kind of be summarized here in terms of plasticity and motor recovery. So what she showed is that if you provide no treatment to these animals, there's no changes in the cortical spinal tract connectivity to the spinal cord. There's no plasticity in there. There is no changes in the representation of the forelimb in the motor cortex. There are no changes in cholinergic neuron connectivity in the spinal cord, and there is no changes in motor. There's no motor recovery that happens as a consequence. If you add a constraint only, effectively equivalent to the forced use that I mentioned earlier, you get some cortical spinal tract plasticity, but nothing else. If you add the constraint plus training of 1 hour a day in the older kittens, basically you induce changes in cortical spinal plasticity and motor cortical plasticity, but not in the other variables. And it's only when you provide the active training in young kittens that you see basically an additive effect of basically the motor training and age. So basically, again, start early and train actively. So back to the ivory tower, Kathleen and I and a number of collaborators basically decided to test what's the importance of kind of this active training component in children. So we did a very small randomized control trial where basically we had two groups. One group was called a structured practice group. And this effectively is habit. This is basically providing bimanual training with active skill progression, modifying the environment, challenging the kid, working on goals, eliciting motor learning and so forth, to try to elicit, effectively using part practice and shaping, and it's very goal-directed. Then we had a control group. We call it the unstructured practice group. Effectively, it was bimanual play. They had the same games and activities, but we never changed the environment. We never tried to, push them in, doing better or faster or, something differently. In fact, the interventionists that they were working with were told, these kids receive so much therapy during the year. This is a recreational camp. Do not change, do not try to change the difficulty or progress the skill as you're doing this. And we had somebody supervising to make sure that didn't happen. And we followed them. This was 6 hours a day for 15 days, and we followed them with a variety of tools and for 6 months. And what maybe is a little bit different than many studies, and we were able to do this in this very controlled ivory tower environment, is that not only were the evaluators blinded, but the interventionists actually didn't know that there was another group. So the play group just thought that, okay, this is what everybody would be doing, and then basically the more habit-like group basically thought that that's what the study was about. So to our surprise, basically for both the assisting hand assessment and the Jepsen-Taylor test of hand function, both groups improved. And they both improved statistically in a statistically similar manner. So we think that we provided so much intensity, 90 hours, that, okay, there's active component in the sense that they all are engaged in motor behavior, that maybe the ingredients don't quite matter as much as we think. And that's maybe a lesson to learn, is that, if you don't know what you're doing, do a lot of it. Might work. It really might work. Okay. But again, we wanted to kind of know more about this. So Kathleen Friel and I have been collaborating, doing transcranial magnetic stimulation, single pulse, not as a rehabilitation protocol, but simply to map the area and strength of connectivity of the motor cortex to the hand and wrist muscles, basically looking at plasticity associated with these training approaches. So, is there a pointer on here? No. Okay. So I'll try to describe this verbally. So on the top plots, you have the child's MRI, and superimposed are the areas in which there were basically evoked motor potentials, motor evoked potentials, when you basically provide a single pulse to the motor cortex. So any area that you see in color basically means that that's an area of the motor cortex that has connectivity to the hand and wrist. And as the color becomes yellow and red, that means that the motor evoked potentials were stronger, and therefore you have greater connectivity. And what you can see as you progress on the top plot with the structured practice child here, you see an expansion of the motor map, and that this is maintained over the 6-month evaluation in the third plot, and that you can see more yellow and red, basically indicating stronger motor evoked potentials. On the bottom plot, you can see that while there's certainly some slight changes in shape, the overall size of the motor representation did not change in the unstructured practice group. And basically the strength of these MEPs likewise did not change. And that can be seen over on the right plots. I won't go into the details, but basically for the finger muscles, you get a large expansion of the representation in the motor cortex with the structured practice group, but very little for the unstructured practice group, and the same thing for the strength of the motor evoked potentials. Okay, so basically, in terms of the motor behavior, there's one thing that I left out, and we think that this is the key. The kids in the skilled practice group, the structured practice group, were allowed to train goals that they and their parents had in terms of function and play and so forth. So effectively, that means that they were undergoing motor learning. And effectively, what you see is that both groups improve on these goals, but the structured practice group that practiced them to the parents' judgment, and they improved more on these goals. So we basically contend it's the motor learning that's associated with this, and this finding, that is driving the motor plasticity. And this is very consistent with the CAT model that Kathleen published a couple years ago. And by the way, she won the Arnold Gale Award for Best Scientific Paper at that time point for that work. Basically, this is consistent with other neuroscience literature, really focusing on the importance of learning new motor skills and driving complexity for a changing plasticity. And I think this might involve more careful look at, well, what are the differences? Maybe these simple clinical tests are not going to necessarily capture some more subtle changes that occur in motor behavior, like skill acquisition, and that's something that we're working on. Okay. I'm not going to go into detail of this, but one is, I should say, that in terms of neuroimaging, Darcy was actually one of the first to show changes in basically the cortical representations of the hand and finger movements in an MRI study following constraint therapy in 2007. And I think that this is really important, something that's important to really understand. Also, more recently, diffuser tensor imaging, looking at the connectivity of tracts of neurons, basically has become increasingly important. And this is the work of Dido Green, and at the time in Israel and now in the UK, basically showing that the integrity of the splenium in the basically in the corpus callosum, connecting the two hemispheres, very, very closely relates to quality of bimanual hand movement. And basically, she and I and a number of collaborators are looking at, well, what are the predictive values of the various structural changes or differences that occur in these kids, and how does that predict response to constraint therapy or bimanual training and so forth. And this is, I think, an area that's very important. Effectively, I've shown you very carefully how to get into the ivory tower, but I haven't really said much about getting back out of that tower. You might need a prince. It's not me. Okay. There are a couple of presentations. Basically, Leanne Saxusi has recently published a paper on this, and it has a course and a free paper kind of describing the facilitators and barriers for implementation of constraint therapy. And then later on, Keiko Shikako Thomas and Darcy and Annette Manamer and a number of other people basically are presenting a short paper on some of the facilitators and barriers in Canada healthcare systems for kind of adopting these types of approaches. I think this is really important to really understand kind of what works and what doesn't, and what are the limitations in order for us to kind of guide the research to better get out of the tower. So one potential way, and this is something here that I think many clinicians know, is to elicit the aid of caregivers, parents, to help provide the intensity of training, especially when camps are not feasible or widely available, and so forth. So my doctoral student, Claudio Ferre, did a study whereby he trained, in this case, 10 parents to do a version of habit in the home environment with younger children, starting at 1.5 years of age. So this is and up to 4. So this is an age group that's been missing in the camp models because these kids are too young to participate in long day camp experiences and separate from their families. And they were basically trained and tested for fidelity of training, and he did a number of measures looking at kind of feasibility and the parents' perceptions and so forth. But I just want to highlight, these are the 10 participants. This is assisting hand assessment. It shows you that between a baseline period of 2 months, there were no changes in hand function. And then when they're given the home habit by the caregivers, and this was done for 2 hours a day in half an hour, up to half an hour bins, for 9 weeks, and basically you get some decent changes in the assisting hand assessment describing bimanual hand function. In terms of, well, what does this mean? All of you know that there's a number of potential advantages of training parents. One is it's very cost effective. You're basically putting responsibility on parents and, increasing their involvement in the care of their child. You're increasing one-on-one time that they are going to be interacting with their children, and, obviously you can provide this intensity at a much younger age than, we can in kind of these ivory tower or day camp kinds of settings. But there's a number of drawbacks. One is it's isolating, to be one-on-one with a child. Parents are not therapists, and we should never think or want them to be therapists. We need them to be parents first. And in fact, by training them these techniques, there are potential risks of interfering with the psychosocial relationships, the aspects of their relationship with their children and with the children of other, I think it's one of the parents mentioned that, there's the other children in the family that you need to think about too. And if you have 2 hours a day with one child, well, what does that mean for the other children? It requires space, and a huge, huge component is the luxury of time. In this case, 2 hours per day. Is not feasible for a large number of families. And we're doing a study now, and we'll report back to the Academy hopefully in the next year. But we're looking at to what extent is certain time limits and space limits and so forth potentially feasible. So another approach to get out of the tower is to use the ongoing therapies in school settings. And this work was in collaboration with Nava Gelkop in Israel, basically who at the time was a school therapist. And she did a small study of 12 children randomized to constraint or habit, basically in their school setting. And what she did is she took these children, and she had their regular therapist who were delivering therapy for 2 hours a day, 1 hour one-on-one and 1 hour in a kind of the whole classroom setting, doing their usual and customary care, which is in her case described as focused on normalization of motor patterns. And then we took the same therapist after 2 months, and we trained them on how to do either constraint therapy or habit. And the kids were then crossed over to receive these treatment approaches for basically 8 weeks by the same therapist. So to our surprise, what we found was that in the 2 months preceding the constraint or habit, undergoing the usual customary care, for the assisting hand assessment and for all the other measures that we took, there were no changes. And then only after they were crossed over to receive constraint therapy or habit did they elicit changes in the way that they choose to use their hand as a bimanual assist, and that this was maintained for the 2 months that we followed the kids thereafter. So school settings might be another option. Obviously in the US and in many other countries, 2 hours a day, even in group settings, is not likely going to be a feasible model either. But it's just starting to think about alternatives and maybe combining parents and school and therapy sessions and maybe other types of summer experiences when available and possible by families to elicit the intensities that are potentially required. So it's not just the intensity. This is showing that ingredients matter too. So that's the active motor learning component of the training that was what we think was added when we trained them to do constraint therapy and habit, and that's not something that most of them were doing beforehand. Okay, so we've been talking about older kids for the most part, and again, I think as one of the parents pointed out, we really need to be thinking about early diagnosis and in really early, catching these kids early and intervening. And Sharon Ramey and her colleagues did a nice pilot study of infant constraint therapy, and she has NIH funding to do a much larger trial, and Rich Stevenson is involved and a number of others. And this is something that I think is really important, to very safely deliver intensive practice in, basically infants, so that we can maybe prevent some of the impairments that, happen at the age that we're already dealing with these kids. And Ann-Christine Eliasson in Stockholm published a nice methods paper and, has presented the results of some of these as well. So we also know from Kathy Morgan and Iona Novak and so forth is that we know that enriched environments potentially have an important role. We know that enriched environments have effects on cognitive development. My colleague Kim Noble in my department at Columbia has shown that enriched environments affect brain development of areas involved in cognition already across the first 3 years of life. So why wouldn't you think that enriched environments would have the potential for affecting motor outcomes? And this is something that they've nicely reviewed and are conducting and are going to report later on in a free paper the outcomes of a trial that they've been doing. Okay. So back to this diagram that Diona had published last month. So far I have focused on basically upper extremity and whole body approaches to rehabilitation. In effect, we can pat ourselves on the back in the sense that we now have several, options that we didn't have a number of years ago that show good evidence for outcomes. But another way of thinking about it is that we've taken the easiest problem, hand function, in the mildest group of kids with CP, and great, we've made progress with that. But we're missing out on the more severe aspects or other aspects of motor behavior, both in individuals with hemiplegia, but also kids with bilateral CP. So let's start with hemiplegia, basically the lower extremity. So my colleague and collaborator, Yannick Blayenhoft, first, I should tell you that she is the recipient of an endowed faculty chair. It's the first in the world of its type. It's devoted entirely to intensive rehabilitation. It's at the University of Louvain-la-Neuve in Brussels, where this institution has really kind of, decided that we need to commit to finding ways of doing intensive rehabilitation. I think that's fantastic. And she has adapted habit to include the lower extremity, so it's hand-on bimanual intensive therapy, including lower extremities, basically by focusing on the combined targeting of upper and lower extremities simultaneously. So basically a lot of gross motor activities. We're so used to having kids in, tables and doing fine table activities, but, the reality is it involves trunk support, it involves, control of posture, it involves walking with objects, and function involves, kind of combination of you can see in these diagrams. That's done by gross motor activities, play activities, having kids sitting on fitness balls, which I know has been used in the past in rehabilitation, but intensively using it to structure the kind of postural requirements and making it more difficult as the kids become better, and doing activities in standing and doing manual activities even while standing on a balance board. So these are systematically graded. And she did this for 90 hours. In her case, in a sleepover camp. She had the luxury of doing this in a park, in Brussels, and basically showed some, as I'll show you, some nice changes. It was a crossover design, so similar to the study I showed you in schools, the kids basically had their ongoing therapy for one group, and we call this the delayed habitile group, and then were crossed over to receive this treatment. And the other group started in an immediate habitile approach, and then were crossed over to receive their ongoing care by their therapist. So red is the immediate habitile group, and black here is the delayed habitile group. And what you see is that the assisting hand assessment shows improvements immediately after treatment, and that they're maintained once they're crossed over. Conversely, the delayed group does not show any improvements until they're crossed over. Same thing for the 6-minute walk test. Basically, the kids that received habitile had improvements in their walking distance over 6 minutes immediately that were maintained, and the other group did not until they were crossed over. Okay. So it's ingredients, again, that matter, these active component ingredients. Their usual and customary care, as described in Belgium, is, again, kind of focused on normalization of motor function. So it's not so much motor learning approaches that were described as being usual and customary care. So what about the more complex and challenging, to boldly go? Basically, the problem of both upper and lower extremity control in bilateral CP. So Yannick Blayenhoff and Eugene Ramakers from the Netherlands and I have been basically exploring the application of these habitable approaches, upper and lower extremity approaches in kids with GMFCS3, ranging from 2 to 4, but mainly GMFC3 at this point, with the idea that we're really trying to target, again, both upper and lower extremity functions simultaneously. And she's going to be presenting that later on in this conference. Okay, so what this basically shows you is the Jebsen-Taylor test of hand function for a group of 10 kids for the more and less affected hands, and you can see that we elicited change in dexterity over a 3-week period. And this is done at the same intensity as the habit and constraint that I've showed you. 6-minute walk test on average, we're getting about a 20% improvement over the 3 weeks that we had these kids in training. The gross motor function measure, we're also getting changes over this period of treatment. And I kind of want to finish just by showing you a case study of a very, very motivated 13-year-old. It's a bit like some of the videos that you might have seen from Camp Independence in St. Louis and so forth, but we have been quantifying exactly the changes that have been occurring. She, as a 13-year-old, participated. She has basically bilateral CP focusing on all extremities, and she participated in our camp in both July 2012 and 2013, received one-on-one training in the same protocol. So this is a 6-minute walk test, and you can see that there's about a 6-fold increase in the distance in which she was able to walk, over the first course of treatment. We brought her back a year later, not quite as good as where she left off, but better than where she started. We gave her another bout of this treatment, and basically she continued to be able to increase her distance and speed and a number of other variables that I won't go into here. So again, these effects are sustained and they are additive. So Steve, if you could start first at the left. This is her pretest walking. You can see that she's capable of walking, but she needs the assistance of a wall or a person. It's very slow and effortful. And if you could activate the right video. So this is just 3 weeks later. It's not biomechanically efficient. Orthopedically, there's lots of things that we could talk about, but from a function standpoint, she can move. She's not using the wall. She's a little bit insecure. She feels like she wants a spotter, but for the most part, she actually didn't really need a spotter because she doesn't, in this controlled environment, fall. Of course, in the real world, it's much more challenging. So this is a 3-week period, we're talking about, and we think that over repeated exposures, over the long course of development, that, there's great practice for kind of applying these basic intensive principles, with very structured practice to include both the upper and lower extremity gains. So I think, my thinking has evolved over time, maybe my reputation, maybe you can call me the intensity guy, or maybe just intense for short. To conclude, first of all, intensity matters. If there's nothing else, that I want you to remember that these intensive approaches are just the beginning, and this is really what is going to drive rehabilitation. We need to provide, maybe not 1 million repetitions, but as many as we possibly can. Dosing, in general, the better. There is a course, actually 2 courses this afternoon about dosing, basically, kind of looking at the importance and the potential dose effects. But it doesn't have to be delivered all at once. Again, we can be thinking about spreading this out as seen fit. Our findings suggest that these intensive protocols can be applied to children with lower extremity limitations, including bilateral CP. Train early and train often is an important message. Now, if I were to try to convince you that, the key to curing this is just training, I'd be lying. That by no means is going to be the case. This is just, one approach of many that has to occur. We need the bridges. We need the collaboration that you talked about, basically the partnerships, and, to be thinking out of the box and out of the tower. We need multimodal approaches combining neuroscience, basically stem cells. We need to be able to do, stimulate the brain, such as Bernadette Gillick and Adam Curtin have been doing, maybe to elicit, faster improvements in response to motor training. We need to basically provide pharmacological treatments, not just focusing on spasticity, but perhaps ultimately to upregulate genes that can, enhance learning, to accelerate the pace of rehabilitation. We need engineering, robotics, but as Diane Damiano showed last year, it can't simply be robotic assistive devices that just try to, reinforce normal movement patterns. They have to be ways in which you can encourage motor exploration and motor learning principles, and those have to be incorporated into these types of approaches. And of course, physical and occupational therapy are hugely, hugely important in being able to further elicit these gains and to basically maintain them and focus on goals and so forth, and that's what's going to be needed to advance rehabilitation. So with the theme of the conference, to boldly go, we need to work together, and we need to do it to get out of the tower and basically to tackle challenges beyond hand function and mild CP. We need to be thinking about, the bigger problems and, basically creative ways of delivering intensity, but maybe more importantly, changing healthcare policies so that basically therapists are given control over the dosing and when it's provided and how it's provided, and basically ways of reimbursing, the intensity that's going to be needed. Thank you.